All right. You're not able to contain yourselves. This is awesome. So what I'd like to do now, as you're settling in from this conversation, a colleague of mine here said, Demian, this picture, what's this about? What are people going to talk about? And look at you. So what I'd like to do now is sample a couple of random sampling here of the population to see what people were talking about. So.
Sure. Hi. Sure. My name's Echo. I'm a pharmacist by background. Just drove in from a different part of Louisiana, and there's apparently a name for what I did that Chris knows. I don't know.
Plus delta.
So I hadn't heard that particular term. I've heard of it called like a compliment sandwich or a feedback sandwich. So I started with what went well and had her walk me through the positives, and then we went through potential room for improvement, just generally as a team rather than her specifically.
What were the topics?
Yeah, it felt like we were kind of working as a team to brainstorm on, hey, let's continue doing these things well, and maybe as a team we can think about doing these other things next time.
Specifically? Not to put you on the spot, I just want to know what the topics were.
Sure, so specifically like the clinical decisions that were made seemed appropriate.
Okay.
And then we were trying to see, like, did we have the appropriate supplies? Like, did we have enough sharp spins? Did we have enough trash receptacles, et cetera, to be more organized next time?
Clinical and the stuff.
Yeah.
Okay. How about this? What do you guys talk about?
Hey, my name is Anita. I'm from Brown. I'm a resident. We talked about, I was like the perspective of the nurse that like found this room and just like didn't know what to touch and where to stand to be safe. And we talked about some like safety measures that could be like made as a systems thing, because like all the trash cans look overfull. So maybe there's like an actual bigger picture thing rather than like putting blame on Sean, the resident, who like was stabilizing the patient. And then, yeah.
Trash, safety,
Yeah.
teamwork.
And then just like having a method for like clearly the patient got what they needed. The room is, like you said, a very successful room, but like what's the process for getting people back in the room afterwards to like make sure that like I can know where to stand to be safe.
Make sure there's some learning from it. Okay. Anybody else?
So she was a resident, and one of the things that was noticed, but there's a lot of equipment that's on the floor, things like the rigid stylet, and there's some also procedural things. So part of the feedback that I explored was the safety of having things like sharps on the floor and equipment availability on the floor.
So from these couple of examples, we talked about the things and the thinking and the behavior, teamwork. Anybody talk about the relationships? Anybody work on emotions? Just curious.
Hey, I'm Amanda. I'm a PGY4 at Boston Medical Center. We kind of came from that aspect of it a little more. It kind of started as like workplace safety and how did the case go, and then kind of transitioned into how do you give feedback in a way that's not really assuming. Like, do you ask questions about how do you think it went, or is that like a leading question that's more condescending in a way, and how to kind of manage that?
Okay, and I can assume those were related to some of the problems that come up.
My name is Ariel. I'm one of the faculty at Rutgers, New Jersey Medical School. I was, I guess, the resident in the scenario, and Amanda, she was asking me, I liked how she said, what do you think could happen from the situation? What should I be concerned about? And then gave me some really different concrete ways about things that I could do differently, and I felt like I learned something from the process.
So first she asked you, then once you played your card, then she played her card. Got it. Okay. So this is one of the oldest pieces of feedback literature that I could find. This is Jack Endy, which I was told is a really classic piece. And to find it, I had to find the scanned copy. And I won't read through each one, but when I read this paper, I was like, oh yeah, it's like motherhood and apple pie. Everyone can agree that feedback should be well-timed and expected and based on first-hand data and limited to behaviors. And it really echoed with a lot of what seemed like set forth the tradition. But when I read this paper, it didn't exactly tell me what to do with it. How do I actually accomplish this? And the other thing that has been influential to me about the idea of feedback is that it's everywhere. It's everywhere in the world. you parked in the wrong space. You could get a ticket, or you could, this is Philadelphia, where I spent some time as well. And feedback is very clear here. You shouldn't have parked here. I had to put the hose through your window. But I think it's that obvious. If you choose to accept it, it's that obvious in the real world. When you walk in, are people greeting you, and in what ways? You can look for it as information across the world. And so, two definitions of feedback that are helpful for me. One is that Jack Endy's conclusion was feedback is the control of a system by reinserting into the system the results of the performance. That was not helpful. So that really took that kind of engineering, mechanistic kind of a view. The Van der Ritter definition was one of the ones that was most influential for me, but it also limited, but it really got me started to think, okay, specific information, I like that's really helpful, about the comparison of the trainee observed performance given a standard. And I think that knowing both what the performance was and what the standard is, which frequently is implicit. We have an implicit standard about what good teamwork is, so then we say, oh, that was good. But we're neither clarifying what is the goodness of the performance or what the performance is, nor what the standard we're comparing it. And I think this is where I really start to get behind it, with the intent to improve, and really in that helpfulness. And that's where the emotional, the relational came in for me. And another influential aspect of understanding these feedback conversations for me comes from the Thanks for the Feedback book, which is the main concept is that there's three kinds of feedback conversations, and that they're frequently either the person initiating the conversation or the person involved in it isn't clear of which domain we're in. So is it about appreciation? Thanks for that hard work. Thanks for being a good colleague. Thanks for working with me. I really liked how this went. It helped me. That's appreciation. Coaching. That worked. Keep that up. Maybe even more specific. Preparing that presentation, those slides were really on point, and it really worked. That is on the performance and not so much on, I really appreciate that you spent all weekend working on those slides and that we were ready. Without that, you're a great partner. So there's two parts of the conversation. And then there's assessment and evaluation, which is summative, higher stakes. And there is some coaching involved in that, but it's really a third conversation. So being clear about why you're having these conversations, I think is helpful, and would take me back to that end of the trauma room, like, well, what am I trying to do here? Is it appreciation? Is it coaching? Is it evaluation? So here's a couple more of the problems, and then hopefully a solution, and then some practice time. So you can take your already useful feedback practice to hopefully an even higher level. As I mentioned before, I think we frequently tell people what they should do, and yet they don't do it. So next time, slow down when you speak in public. Well, I'm still not doing it. So why not? I think it's because you told me what to do, but we didn't work on what's driving that. What is it that's getting me there? I think we may know what they're doing, but not why. And so in the good judgment approach, which is this method that we develop at the Center for Medical Simulation, we have a stance of curiosity and respect. And what's the curiosity about? It's not about the standard. It's not about, from that feedback definition, it's not about saying what was the standard and was it met. That's your perspective, you're observing that. But it's the curiosity about why this person, this team, this group got into that situation. And so the strategy is all about uncovering the frames of reference, the mental models, what's behind those actions. And so instead of giving feedback, we enter this feedback conversation or learning conversation that is all about getting to that question, and not starting with the question, but getting to the question. Because in the model, you can see the actions, how they're speaking, whether they turn away from the family when they're asking a question, You can maybe see the result. That family then throws the papers to the ground and walks away. You can see those things, actions and results, but you can't, and so you could coach there, but you can't see the frames that led to that. The assumptions, the feelings, the goals, the knowledge base, which is really not usually the source of the action, but because I just assume people have a lot of knowledge, they've gotten themselves past many years of schooling and licensing, et cetera. That's not usually the problem. Might be the situational awareness, what they're focused on at that time, what the other patients outside of that encounter. There's lots of reasons why they might be heading into that action. And so the opportunity for you is to not only coach on the action in that feedback loop, but also to explore the frame and then try to share your expertise, try to help people reflect on that frame, consider changing that frame. Your colleagues and your trainees are adults. They're going to change when they're ready to change. They need the information and motivation to make those decisions. That was a heavy cognitive lift, that theory moment, so let me reward you with a video that I think will make the point. And then you'll tell me. It's short.
Scusi, buon uomo? Mi sa dire l'ora, per favore?
Le 5:35.
Ma è sicuro?
E 36.
Grazie.
Prego.
Ha mangiato il ciuchino, eh?
No?
Senta, mi sa dire che ore sono adesso?
Allora. Le 7:15.
Oh, ma sono le 7:15 spaccate. Incredibile. Ma lei come fa a leggere l'ora nelle palle del ciuchino, scusi?
No, io le alzo. Sotto c'è il campanile, vedi? Già vedi? 7:15.
So I think of the farmer as that amazing new colleague who does things really differently, and you're like, oh, there must be a reason why they're doing this. Like what? And so the tourist on the Vespa, I think his initial strategy is to quiz the person and test them and really like certify, like, well, are they really doing this right, or are they getting lucky? That's not satisfying enough, and so then he gets into the good mode of asking, like, well, how how did you do that? And so then he gets the explanation of the mental model. So I recommend you try out being the tourist, observe a performance, have a standard in mind, right? Like getting the time right, that's the standard, you're getting it right. Then you're gonna use this method of preview, advocacy, and inquiry in that step to explore the how did you know that, why did you do that, a past tense question that gets at what was the driver, the frames that led to that action. So I'll give you an example, and then I'll leave the guide up for us to work. So here's my guidance. Specific factual observation. The observation should, did I skip the preview? I skipped the preview. Preview, okay. A key step. Preview is going to be orienting, okay? I'd like to talk about choice of medications use, teamwork and decision making, patient safety, improvements we could make. So you help your colleague or trainee oriented to what conversation you're interested in having. You're playing your cards first. Judy, I want to talk about the jacket and the shirt. The choices there. Orienting. Okay, it's not judgy. I didn't say the great outfit you're wearing. It's orienting. Another way to think of it is person, time, and place, just like in orientation in the clinical setting. I want to talk about right before EMS arrived, that conversation Denise and Ernesto, you guys were having. I want to talk about that moment for a few seconds. What do you think? There's like a mini implied consent here, informed consent. Like I give that pause. Are they willing to enter into the conversation? be as specific as you can, right? So I want to talk about communication, too big a topic. I don't know what Danny wants to talk to me about, okay? Responding to anger, much more specific. Then I want you to share what you saw, your observation. Observations in this context should be recorded or photographed, could be recorded or photographed, could be admissible in a court of law as evidence. Okay, so Demian, I saw you getting frustrated. You can't see frustration. I don't think that's admissible in the court of law. You might see me pacing, me being shorter in my responses, me stop talking, and maybe me say, I am frustrated. Those are your observations. Your judgment or point of view, that's the second part, the second part of that I've said. I'm worried that you were frustrated in that moment and that led to not as good of a decision. And then going to the open, curious question, so talk me through that. What was going on for you? Which leaves that room for uncertainty. Like maybe Demian wasn't frustrated. Maybe something else was going on. Maybe he was rushing. Maybe he was trying to accomplish something else, and you let me kind of talk through that. So we're entering into a conversation as opposed to you delivering feedback. I know that's not perfectly clear, but I know you have amazing coaches to work in the small groups, so I want to get you there. And so we'll spend the end of the session working on another video example, and if you have, and you'll be tweaking it as you go with in your small groups. So central line insertion, I'm hoping people are generally familiar with the concept. Sterile field, pre-COVID, so we're not going to be fully compliant here. You're going to meet Dr. Minuti. He is placing a central line. You're going to meet Tony, the nurse. Tony's really like capable, intelligent, trying to do his best, trying to help Minuti, who contaminates his sterile field during the course of the procedure. So as you're looking at this, take a note, make a note of things you're observing, and make a note of your assessment, your judgment, your point of view. And then you'll be able to pair up again and enter into a conversation with either Tony the nurse or Dr. Minuti, okay? Clear as mud?
Dr. Mead, do you need any more help? No, I'm good, Tony. Mr. Davis, stay still, okay?
Right there.
Dr. Mead, do you want me to get you another one of them? No, I don't need anything. Tony, what are you doing? I didn't ask for anything. Just, Tony, did you check on that tetanus in Bay 4? Yeah, I'll go check on it. Mr. Davis, now stay still. It's only going to take a few more minutes.
Okay, I'll play it again, but just to summarize, Dr. Moody's placing a central line. In the course, he uses the barrel of the plunger of the syringe to adjust his goggles that were going to fall in. And then Tony comes in to say, do you need any more help? Did you? And tries to give him a new syringe. So here it is one more time.
Dr. Mead, do you need any more help? No, I'm good, Tony. Mr. Davis, stay still, okay? Dr. Mead, do you want me to get you another one of them? No, I don't need anything. Tony, what are you doing? I didn't ask for anything. Just, Tony, did you check on that tetanus in Bay 4? Yeah, I'll go check on it. Mr. Davis, now stay still. It's only going to take a few more minutes.
Okay, so I'll leave the general guide up here for you guys, and we'll take about 12 minutes or so. Have a couple of rounds in your small groups of practicing initiating the feedback conversation. When you're the role player of either Tony or Minuti, think about what could be some possible assumptions, goals, etc. that could be leading, and it's especially helpful if those are surprising or interesting and amenable to then entering into the rest of the learning conversation. as clinicians here, we're diagnosing, we're not treating or fixing. Okay, that's the advanced course. So today we're just doing the sharing your point of, stating a goal, topic you want to be in, the preview, saying what you saw, saying what you're thinking about it and the implication, and exploring the mental model.